colleagues, and dear friends. With the pleasure of visiting such a grand institute with the foundation. I am from Jaipur. I remember my fitness days. You are as big as this hospital, and we always say that the crux of the healthcare delivered in the government hospital. Let's change some tracks. This is the Cardiology Cardiac Surgery Institute. I will not take a single word about cardiology today. What Dr. Doshi told is very important that the team gets stuck only two times: infection and a vascular event. So we all know people who are undergoing cardiac interventions can have a infarct, hemorrhage, which can be a cerebral or cardiac hemorrhage, or they can have a low flow encephalopathy, or they can have hypoxia. And these things that happen with any surgery can be catastrophic, which is beyond anybody's control, but they happen because they happen. And this leads to disorders of consciousness. With patients are lucky if they have a minor stroke or a minor bleed, they will regain consciousness, they will go home as other patients. But if they have a massive bleed or a massive infarct, what happens? They go into coma, there is no eye opening. And then when they start opening eyes, but they don't observe responses, it's called as vegetative state, now called as UWS, unwakefulness syndrome. Those who are lucky started opening eyes, show some purposeful behaviors which are non-reflexive, that's called as minimally conscious state, which is again divided into two parts, an MCS minus or an MCS plus. MCS minus, there's some gaze pursuit, they will look around, scan people who enter your rooms, or they have a higher level of function, they can respond to simple command, they can nod, they can keep a hand up sometime, called MCS plus stage. And then patient can emerge from there. It's called as emergence or MCS to a functional communication. That's called as conscious state. These terms are very important because those who reach MCS in the hospital might regain consciousness in future and become more independent. So my talk today is just how to convert these DSMCS into C. How can we make these patient vegetative state and conscious state to regain consciousness or improve their different functions, become more independent. Before I start, there's some myths being prevailed, which I was also used to. I was told in my medical days that patients with severe brain and stroke should be discharged home when they often anticipated. Because our job is done. It happens to that 90% hospitals in this country. It's irony. Second, they don't recover after 3 months. जो होना है 3 महीने में होना है. That's a wrong concept. Inpatient rehab is more advantage over home care. घर ले जाओ सब अच्छा हो जाए. With toxicity, plateau very early after pharyngeal stroke. No. And patient need rest after stroke and burns. These are common myths being prevailed in society, in healthcare professionals and physicians, in families. Everybody are equally part of it. If you can break these myths, make people better. It is like this. Somebody had a simple surgery and had a massive AC and MCS stroke, dominant side. Somebody had Atlas syndrome and a big family infarct. Massive bleed with external injury. Do you think people walk again? Can they be independent in the community? Is it possible? They're lying at home and something in the ICU or at home. I'll show you at the end how they are. These CT scans and MRIs, people can change if they get good medical and legal care. Some basic principles. The most important slide. Remember these timelines. The best predictor of recovery are etiology, what is the reason of result consciousness, the age, how long you were at home. Always remember, we can label them as persistent vegetative state, not likely to change only at 3 months post hypoxic encephalopathy, and at 6 months post stroke, and 1 month post brain injury. This is documented data. We think they can't improve. You know, see the journey is not life. People can change. If you can do intervention in this time period, people can become conscious, can become effective. These numbers are very important to remember. And also, those who have survived or have become conscious can still have all these problems. Cognitive, behavior, vision, speech, language, swallow, tone, bladder, bowel, sensory, motor, pain, sleep, autonomic dysfunction. So the job in rehab is to make them conscious if possible, and then if they are conscious, identify what problem they are having now. If you can't pick up, people with minor strokes regain mobility, but can't go back to work. They have cognitive issues. They will never screen their life. MMSC is not a good test to screen people with cognitive deficit who already have a stroke. Something beyond that. You screen for all these deficits and then make a comprehensive plan to treat such patients with the help of your multi-point team. Now, somebody has a stroke in the ICU. We all know this test. We all know this test. We all know Kasarkoma scale. We all do routinely in our life. And that scale is good for neurosurgical or neurological concept in the beginning. From rehab perspective, a very important scale is this JFK Coma Recovery Scale Device. This test can differentiate between vegetative state patients and minimally conscious state patients. Pick them up early. You pick MCS early, put resources there, put more efforts there, they will recover faster. You can have a triage. Which patients will spend 3 weeks, 4 weeks in the hospital, will spend too much in the hospital. Do this test, pick it up very, very early. And then you're planning their rehab intervention for that RNA staging, Rancho Lodge Amigos case, which describe any person with a brain insult, how he recovers from no response, generate response, local responses, confused, agitated, appropriate. Most of the rehab happens in stage 3, 4, 5. They are inpatient candidates for inpatient data. And then how they are at 6 months or 1 year is called as Glasgow outcome scale. GOS 3 also is okay. Somebody who survives a massive stroke or hemorrhage, if he can live at home with the family with GOS 3, it's a good outcome than dying or being in the hospital because he went for life. So even if you achieve GOS 3, we all think the dedication back to normal. It's not possible sometimes. Meaningful recovery also is an important concept. So we can make them at least live at home with the community to good achievement in patients who have massive diabetes strokes. So what happens in a massive stroke or a brain insult or an hemorrhage? We all know in the beginning there will be mass effect, some reperfusion. We know we can reperfuse the brain by an IV TP or cord retrieval. Brain in itself first few months, what happens? We know that. It's a known concept. But there are some medications which can change the outcome of language recovery at 6 months. There are. What are the sub-acute stage is most important concept? Brain recruit additional areas to perform new function. This is called as compensation. Or other part of brain takes over function. That's called as reorganization. This ability of brain to change in response to a stimulus is neuroplasticity. This can be triggered by intensive training called as experience-dependent plasticity, which can be physical therapy, occupational therapy, speech therapy, solo therapy, cognitive retraining, or newer treatment, pharmacology, HPOT, and stimulation. We'll see all of them in short one by one. So what is the most important concept is to task-specific training. If God has made hand to eat and drive, not to exercise. God has made legs to walk, not to exercise. If you can make them do those functions, if they are made for, there are engrams in brain. There are patterns of movement in brain called as engrams. If you can make a person do a specific daily task when he has no power, you can still do it with technology. You can trigger the engrams. And patient get new recovery which you never thought was possible. So what we're doing in rehab is to trigger the plasticity to get newer recovery in different cognitive language, swallow, speech, or pedagogical domains. So, how to train the brain in the initial period? We all say, we all like a therapy first. That's what we say. Is therapy enough? What dose of therapy? What frequency of therapy? What type of therapy? What components of therapy? What use of technology? What NI pharmacy and happen you do with therapy? All are important components for recovery. And see, this is from Europe. Patients in a good ICU, in a rural care, small nursing home hospitals, spend 80% time in a bed. Even in a tertiary level hospital, they spend 70% time in the bed. So one thing you can tell the patient and family, make him sit edge of the bed 2 hours thrice a day. Make him sit out of bed 2 hours thrice a day. At least 6 hours he can spend out of bed. This is as potent intervention as a therapy session will be, and it costs nothing. The trunk control improves with that. Partial verticality can achieve it. The current treatment regimens, what we were told earlier, has got a limitation. Patients have a lot of severity, they can't practice, they have poor motivation, minimum repetitions, limited time for therapists available. There are 6 therapists for 1,000 bedded hospital in Doshi, sir. Here are the numbers. No feedback, unclear feedback, changing need of patient, lack of manpower, cost. This trial showed just giving therapy 5 times versus 6 times per day. In Australia, the length of stay came down by 30%. How much money can be saved for government, or how much cost efficiency we can have if we give more dose of therapy in the acute facility. We call this as 666 concept. So our patients are admitted with inpatient neurorehab with stroke or a brain injury or a hemorrhage get at least 6 sessions of therapy, 45 minutes, minimum 6 days a week for 6 weeks. We work 12 hours, the works 8 to 8 every day. The patient has 12 hours to finish therapy, and patient do at least 8 sessions of therapy in a day. 6 plus do I do the robotic and all that. So you have to trigger that plasticity when brain is right. So within that period, you might not change. To deliver that, huge team is required. Huge team is required. We have a neurologist, a neurosurgeon, intensivist, rehab physicians like me, nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, orthopedic nutritionists, all have very important role to play. It's a team which delivers, not me or anybody else. It's a team that delivers, gives the outcome. What interventions we can do? Somebody has a massive stroke, he's in the ICU, post-cardiac arrest. He requires 5 things. First, he still has tubes, he has diabetes, he has hypertension, lot of comorbidities, he has AF. You have to provide continuity of medical care. Second, they are liable to have very common 5 complications: aspiration pneumonia, DVT, contractures, pressure ulcers, infections, UTI. Prevent and treat those secondary complications. And third, with the help of your team, provide training for sensory motor deficits, training for cognitive, communicative, and motor deficits, and manage their psychological and social issues. But while doing it, it's not that easy. It's a massive cardiac surgery event. So people have now a lot of medical complications. When I was talking in the morning, we have more complications now because this is quadrant level care hospital. They get all complicated patients. These are older people, sicker people, multiple comorbidities, with advanced interventions. So we have mortalities, we have morbidities in the hospital. And basically, your brain insults, everything goes wrong. Control is there. If control is gone, you will have newer onset cardiovascular, physiological, endocrinological, immunological, respiratory, all types of problems. And sometimes you know the problems. You don't know, you can't pick up. You can't do therapy because you have these issues. You have to manage all these things so they can do their therapy, otherwise, waste of time. And some complications are unique. These 4 are unique to patients, especially with brain insults. massive strokes and injuries. Those four are very common as paroxysmal symptomatic heart activity, called as PSH syndrome. These patients will have fever, tachycardia, tachypnea, dystonia, posturing. They are put back on ventilators, put back on Fenta. There's no treatment. Treatment is to give them beta blockers or bromocriptine, reduce the symptomatic drive. Yes, you go to ICU many times, sir, you can't get this patient. Why? He's very agitated, he keeps starting posturing. What we do? President calls, sir, I put the Fenta, put the ventricle. That is sleep and memory. That's wrong. You're spending 5 days extra time in the ICU because you're not aware of it. Patient is very weak, he himself has these issues. Second, agitation. Cognitive confusion, making emotional lability, motor activity, verbal aggression. Most of the time it is technical medical problem. Something called as plague bed concept actually. In Europe, they put floor beds in the intensive care center. They can have time to relax. Yeah, lying in bed, fatting in the bed, put them on the plague bed, which is a proper floor bed with all four sides covered. And very commonly, you give sedatives very early. Don't give olanzapine, pitapin, haloperidol, when it's not required. Leave this, they will not require. If you have to give, please access that to newer one. Don't use the older ones. Haloperidol is more old. Use pitapin or olanzapine in the most safer situations. Another issue is tone abnormalities. They just go into hypertonic. And all of us think tone abnormality means spasticity. No. It can be a mix of spasticity, rigidity, and dystonia. The medications are different. You can't get better from everybody. They may get tricyclic or levodopa also. And also, something called as sequential versus integrated complex spastic management. We were told those that you first start stretching, then you give us splint, then you start the medication, then you give botulinum toxin, then you do a surgery. This will take 3 months and get it already accomplished. Start stretching, give us splint, start medication, not helping, then give botulinum toxin, phenol, whatever you are trained for. And now, with the advances we do, now use ultrasound very important toxin. All injections are guided now. The thing is blind. We can do a phenol block for the nerve or botulinum toxin to the muscle with guidance. This was EMG earlier, now it's ultrasound. Even evidence to show that it's better than manual treatment. So always use guidance with botulinum toxin. Fourth complication which we see normally is, which is again missed. You get many patients but that will come with a, you can't bend the hip or the knee. You can't bend the elbow or the shoulder. Why? Because they have formation of new bone around the joint. This is formation of normal bone at abnormal place. It's called as myositis ossificalis, controlled ossification. And once you have it, this bone, this light gives a necessary remove the bone. Otherwise, you can't go back to your mobility again. We can prevent it. We don't do aggressive stretching. We can start the medication, bisphosphonate in initial stage in patients who have massive injuries. Or if you have it, you can give bisphosphonate indomethacin with topical decompression followed by single radiotherapy to control that. So if you don't do these four things, these patients will have a lot of problems and therapy often is not good enough. So to make them good enough to undergo therapy, the outcomes are better. If they have many complications, the partner therapy is very, very poor and the outcomes are pretty. Now comes what we can do. There is no chapter on any textbook on disorder consciousness. We wrote one few years back. How can we improve outcome patients with brain insult who are in disorder consciousness? Marginally 6-7 days, we see in short how we can improve. You all know this slide. That's the backbone of any therapy intervention with a stroke or a brain insult. There's neuro-ecological therapy approaches, OBA, TNR, Boonstorm, motor learning. They are basic, everybody knows it here. Without it, you can't move forward. You can do that to bring it in bedside of the patient. What are the next step? Next step is to mobilize. You get scared when to mobilize. The nice guidelines. Not to mobilize, it not only can walk in the ICU. These are published long back, and they are hold true for most of the patients. If you can do that, starting early verticality is very, very important. A simple tilt table in the ICU can be a game changer in long term. Or now we have systems where there's FES inbuilt in the tilt table. There is no posture of blood pressure, called an Erigo system. The person is made to stand. What next we can do? We think this is useless. This is the most cost-effective intervention. Multimodality sensory stimulation. Brain, the gateway to brain are sensations. Motor is the outcome. We have auditory, visual, gustatory, olfactory, tactile, vestibular, vibratory. All these systems are there. We have to use this simple kit. The kit has all these components. We can do multimodal stimulation 20 minutes. We can do 40 minutes twice a day earlier. Now they have shown that you do it 5 times a day, even more better. Reduction, based. MCS can become C, US can become MCS, multiple intervention. Make them stand, start bedside multiple system push. Doesn't cost anything. We have family members in India who can do it. They have kids, give to them. Cost just 100 rupees. Then Indians love music. You can use music to improve their arousal, their attention. They calm down. Again, it costs nothing. You have trained musical therapist in the hospital who goes bedside, who actually plays guitar and drums, they are bedside competition by ICU. But you can train family. And research people have shown that people who got additional intervention of music therapy in vegetative state, MCS state, have better outcome than music. Also remember, music can stimulate multiple parts of the brain. One of the most potent intervention you can do, which costs nothing. Again, it is multimodality. You hear, you feel, prosody, rhythm. It activates temporal, frontal, multiple parts. Then, failure to make them stand. Can they start stepping? This is a very old system, but it holds true also now. It's just a body weight support system. It's a frame with a body weight support. You can make a person stand and make him walk on a treadmill. Which you can do for people for ACS 8 with tracheostomy, you can also do it. You start very, very early. Make them start stepping early, outcomes are much better. The same device, keep robotic devices. This is Locomat, which has now 2000 installations in the world. It is the most potent device which can make a person walk. So our patient with disordered consciousness, with tracheostomy, with GCS 9 walk on one wall. Those who can stand in the tilt table for 30 minutes can walk on the machine. And especially for strokes, it is evidence based now. Walker and review rarely give evidence in rehab. They say do more trials. But they have shown that every quick dependency in walking after stroke could be avoided if you combine this training with conventional therapy. And it's useful for non-ambulatory patients. Always remember, these systems are only for those patients who cannot walk. If they're able to walk, robotic device is a wastage of time and resources. Many people do it for 6 months. No. If you can't walk, you do 20 sessions, you gain mobility before it is fought. Once you start walking on the ground, this is not required. Conventional therapy is good enough to take away. Always remember, this is done in conjunction with conventional therapy. Same way, the person can sit. There is no power in the upper limb. Now God has made hand to not to exercise. Knee, ring, right. How you can do it? Need again upper limb robotic systems. This is the army of power system. Somebody has no power in the upper limb. You can just trigger his shoulder. What are you doing? With the exoskeleton putting an armed system. You do a daily task on the computer, cutting an apple, driving a car. Whatever you are doing, you do. What you can't, the robot will sense it in 3D plane Give you that stimulation, you will complete a task. This task completion triggers the engrams in the brain. They are subsequently motor reflexive of function. It will become better. When there is some power in the shoulder, you work on the forearm, elbow, as well as armio spring. The same lady, actually, with a massive stroke post surgery. And then they can work only on the hand, which is called as a variable. So remember, in one session for 45 minutes, a patient can do 1,000 times breathing feet, 1,000 times breathing feet. You can trigger your shoulder, elbow, forearm, wrist, finger in a sequential way. That's how brain functions. Very much like this. It's not about this. It is evidence based. Okay, never says that people get training along with physiotherapy, you get a HKF, better arm function, better arm muscle strength, clear dropouts, clear wrist strength. Also, the analysis says that you can gain figure mass. You know figure mass there? For motor impairment, gain figure mass score of at least 8.846 points by this training, which is meaningful. Again, it's more useful in the acute and subacute stage. So somebody is 6, 8 months post with the robotic system, it's on the list. People are doing it. It's not required. Only when they can change, use it. Otherwise, they will not work at chronic stage, but it works very well in the subacute stage. As physicians, we will start some medications. Are there any medications to improve? There are. So before adding any medication, we go to ICU. People are on these medications, very common. Haloperidol, prazosin, Promethein. This is like phenytoin. This is get Nordic to a patient. This is get Parkin to a patient. These are very good drugs, very effective drugs. But they start doing recovery. So remember, talk to your colleagues, shift to a safer substitute which are available now. Now for arousal, it's a complex cartoon which shows how substantia nigra and pars compacta have multiple up and down regulation systems where primarily the dopaminergic pathways, we can add dopamine analogs like donepezil, bromocriptine, and phenytoin, amantadine, or cholinergic analogs like rivaroxaban. What is proven in research is amantadine. Amantadine is proven to improve level of consciousness in patient brain cells those who are in vegetative state. So always give a trial 100 PD, next 200 PD, they might have seizures. Also, what is very commonly used as that drug or zolpidem, there are some case studies where people have paradoxical arousal. Those who are not sleeping got zolpidem, slept well, for 5 days woke up. Not very useful in non-drug drug. But amantadine must be added in most of the patients. What's coming new is hyperbaric oxygen therapy. It's a chamber. This chamber has oxygen at a higher pressure. So right now we are at 1 atmospheric pressure. The amount of oxygen, dissolved oxygen in the plasma is 0.3 ml per deciliter at sea level. In this chamber, patients can go to 2 or 3 atmospheric pressure. So if you have 2 atmospheric pressures, the oxygen contained plasma is 4.4, 12 times more than 0.3. What it does in neurogenesis, uses ICP, promotes apoptosis, cell death. The patients who are having massive brain injury, brain insults, hypoxia, we use it in most of our patients. But all of them are GCS, there's a 9, they are on tracheostomy to ensure they can spend at least 1 hour inside the machine. It's not easy. Even if you stop the machine open, it takes 5 minutes to decompress it and push it out. The last 12 years we are doing it, we have no major complications to it. But if you maintain, that patient can maintain 1 hour of without section, at least 1 hour section. They can manage if they have sugars more than 100, no active seizures, no EEG, they had massive seizures earlier. no active seizures, sugars are more than 100, 1 hour suction free, to go in the machine for 1 hour. They will require at least 20 sessions. So most of the patients do 666 plus 1 HBOT for 1 hour. And we have shown that in patients who have prevent ICH or strokes, who underwent decompression surgery, the outcome is 6 months of this, which means 50% of patients with GOS more than 2 to 3. And you get outcome, especially was stuck in the ICU for years. Also, we heard of brain stimulation now, RTMS, PDCS. They are currently under research protocols. What's very commonly used, which costs nothing, is peripheral median nerve stimulation. Right median nerve represent big part of the eloquent cortex. By a 50 Hz stimulation by a small portable device, you can train the right median nerve stimulation for 8 hours per day. 8 hours per day. If you can do that, it costs nothing. Your family can do that. And if you do that, the evidence will show patients that people are than especially minimally conscious time. There are cases on that with the students, especially in MCS stage, especially in brain injury more than stroke. That's a lot. That costs nothing. Music therapy, peripheral nerve stimulation, multiple sensory stimulation, they cost nothing. Standing, sitting 6 hours per day. Also, what we normally missed, and we have a lot of aspiration in the ICU with tracheostomy, because we don't have an organized dysphagia evaluation protocol. There's a GUS test, GUSS, and you can download that free online. Anybody can do it. A nurse can do, a therapist can do a GUS screening. Beyond GUS, we made our own protocol for evaluating dysphagia, cognitive status, check all the cranial nerves, do parallel trials, and then make a decision. And also, if we follow a decamation protocol, we can decamate 80% of patients with vegetative state also. And that means the cost of care post discharge at home comes much less. Somebody goes over tracheostomy to keep a nurse with them, it's very expensive. If you decontaminate them, they go without a tracheostomy, cost of care just comes down to it. The patient's family know he may not walk again. Can I take him home? No. And bigger differentiator is decontamination. So if you follow protocol, you can decontaminate most of the patients. This is called a modified Ivan to dye test. Tracheostomy, it's a cuff tube, for suction port. If you can just deflate the cuff with some colored liquid, blue or green color, the toxin tracheostomy section, dye test failed. Don't deflate the cuff. Dye test pass, you deflate the cuff, put a valve, it's a passive way speaking valve. People can eat with tracheostomy, people can speak with tracheostomy. No. It is non-disclosed. Start that, and then to 24 hours of deflation, they manage it. We all have fluoroscopy or X-rays. You can do a video fluoroscopic follow study. Very simple test. Give them liquid, semi-solid, and solid, and see where it's going. It's going straight to the esophagus. It comes in front, the laryngeal vestibule. It goes down the aspiration of communication. If you can pass this test, you can block the tube. You can easily decontaminate most of the patients in the ICU. Just take one or two examples. Same patient. The family came to us at 1 month. The boy had a loss of consciousness, can't speak, all the tubes possible, and a decompressive connect. What you can do, you do all this stuff. Mechanism of stroke, secondary prophylaxis, antispastic medication, botulinum toxin, do donor-based prevention for aphasia, fluoroscopy for swallowing, decontamination, USG-PVR, blends, physical therapy, occupational therapy, phonotherapy, pre-cannabis therapy, bladder board training, family counseling. There is 6 weeks. If you can do that, then biotechnology. Sure. Then robotics can help. With one walking 300 meters every day, which is huge number of steps which you can't walk otherwise. And at discharge, you get to walk. There's nothing here. So brain can change. You have to make that change to happen. Another lady had a postpartum cardiomyopathy. Now, that MCS too. She was told, don't walk, you will die. Here is 50%, which is reality in part of the country. Who are here? Lie in bed, take rest. This is a functional MRI. This is supplementary motor area, which took over function in intensive training. So research has shown that with arthritis training, this is why the damaged part of the brain. These are the supplementary motor areas which took over function and she got mobility back. The same poor patient that we see again, bad Aplar syndrome, bad hemorrhagic stroke, he actually drives his own car independently, bad ICA, MCA stroke, independent. This boy was a discharge like this, now works in the community itself, another guy, they all become independent. Patients can walk, patients can become conscious, patients can improve. What makes that happen is this concept. What is right for your life will help you. We all know you can reperfuse the brain in first few hours. IVTPA, torque retrieval, decompression switch. There goes under trials, that nobody questions that. Swelling comes down in first few days. Brain tries to change itself in first few months. That finishes at 3 months. This will happen irrespective of what you do. There's good medical care, better therapy is enough to do this. That's why we were told 3 months के बाद recovery नहीं होती, which is wrong. It's actually wrong. If you start intensive protocols in the first few weeks, get something new. That is training induced reorganization. That's applicable for every domain. Cognition, behavior, speech, language, swallow, mobility, all can change if they get specific training for psychotherapy, what is required for that. So always remember, we were told if somebody can't walk, be rested, can't talk, is sign language. That was compensation. It was disability management. And we focus on the disability, not on the ability, and we gave him more learn, non-use. If you were able to walk to the washroom, you don't walk, you take a stick, take a wheelchair, you take no use. We focus on disability and give him more learn, non-use. Current era, modern day rehab, is payment-based treatment. I have in a presentation on cognition, behavior, speech, language, motor, grammar, vowel, sexual, tone, sensory dysfunction. If you treat all of these impairments, you can even disable them. That's the concept of current modern rehab. The same myths which we all born brought up with. Patients with brain injury and stroke should not be sent home, should be transferred to a specialized center offering comprehensive neurorehabilitation. Patients with stroke and brain injury don't recover after 3 months. Functional recovery can happen in up to a few years post-injury. We have published long back, 20 years back, 6 months to 10 year post-stroke patients who are non-ambulatory, who were trained for 6 weeks. Spastic management, botulinum toxin, intensive therapy, 1/3 learned to rest. Because they have movement, they never got rehab in the floor. It's irony. They were therapy naive. Third, plus inpatient rehab is an advantage. Inpatient rehab significantly reduces death, dependency, and long-term care. How can reduce proven? What doesn't help? Robotics help in the subacute stage to improve upper limb function and lower limb mobility. Subacute stage, not chronic stage. Neuroplasticity, that is very early. No, plastic can happen months to years post stroke or brain injury if they get good treatment. And patient need bed rest after stroke and brain injury. You were told, rest करने को भी तो बड़ा चोट लगा है, बड़ा stroke का rest करना है. They need supervised neurology program. And also, We can give oral feeds in lying down position. The best habit of our parents, they will make the kid lie down and then they will give feed to the tracheostomy or the larynx tube. Always part of the These simple myths have to be broken in society to help our patients. Just to summarize, how can they improve the outcome of the patients without consciousness of causing a stroke, a brain insult, or hemorrhage? Prevent, recognize, and treat. All three are important. And to prevent, and to pick up early and treat. If you can't do, these patients can't do rehab. Second, multi-modality sensory stimulation is a low-cost intervention. Doesn't cost anything, 100 rupees. It can be more effective to multiple times in train caregivers for that. Trial of MST must be given to every patient with ES or MCS until unless contraindicated. Proper tracheostomy care and decommission protocols are necessary because they can reduce the cost of care significantly for a period of time for a patient with families. Hyperbaric oxygen therapy is effective when combined with intensive neurorehab. The evidence is coming out now. Music therapy is an effective tool to improve organ communication, again, very cost effective way. Early mobilization and robotic step properly in training is started very early to improve the outcome. And evidence says do it for non-ambulatory. Yet many people doing it for ambulatory patients also don't do it. Neurostimulation, especially peripheral medium nerve stimulation, can be a very good option for patient with MCS. Thank you very much.